enjoying us this symposium today. Get up some lunch and then make sure that you're all participating, sending us questions. But we're excited to talk about resectable gastric and GE junction cancer today and all the exciting new research and data that have just been published. I'm Daniela Molena, by the way. I'm a thoracic surgeon at Memorial Sloan Kettering in New York, and I'm joined today by my co-panelist here, Samuel Cytryn, who is a medical oncologist at Memorial Sloan Kettering, and Molena Shah, who is medical oncologist at Cornell University. So we'll have a lot of multidisciplinary discussion. I want to thank PeerView for providing the session and also AstraZeneca for the support. And you've heard there's a little bit of a possibility of winning some prizes at the end. So please complete the pre-event survey and then answer the questions that will be popping up during the presentations. The Q&A is going to be at the end, but you are welcome to send questions at any time during the presentations, and we'll make sure that we'll keep them in consideration and discuss that at the end. There are some QR codes during the presentation, so you can just see the slides, log in, and also answer the question through the QR code. We have an audience online as well, and we want to make sure that also they can participate to our poll questions. So here is the QR code. I'm going to leave it there for a second. There is a survey and then some questions. And at the end, if you win, you'll have a message that comes to you on your phone. So we don't get to celebrate all together, the winners. You can see the slides at the end of the presentation, always by going in the QR code. Okay, so let's get started and see what the goals for today are. We'll look a little bit about how the field is evolving, and especially how we can use immunotherapy agents and regimens for the treatment of esophageal, gastric, and GE junction cancers. We're looking also at some options for personalized care, to incorporate for patient direct concerns, and the importance of the multidisciplinary collaboration. So I'm going to go and get started setting a little bit the tone, and then I'll give the mic the word to my colleagues here. So as you know, why do we care? We care because this is unfortunately a deadly disease. For many years, we really had not had anything good to offer to our patients. And the number of cases has kept increasing, but we didn't really do much better in terms of treatment and being able to cure patients for the disease. And an estimated 1.2 million people will die of gastric and esophageal cancer in 2025. And so I think that hopefully the wave is turning around a little bit and we can do a little bit better in the future. So there are definitely some challenges in the treatment of this disease. Overall, esophageal cancer, GE junction cancer, and gastric cancer has always been considered a pretty deadly disease. The incidence and the number of mortality, if you look at the curves, are pretty much one on top of the other. And there is also a perceived feeling that some of the medications that we use for our patients are very toxic, and patients are not going to be able to tolerate them, and debilitate them to a point where we cannot safely perform our surgical procedure, which is one of the most important part of their treatment. And then some issues and concern regarding immunotherapy agents. When can we access to those, and how can you use it? So let's start by the past, and I want to think that we all now believe that this is the past. Esophageal and GE junction cancer is deadly. Mortality with survival with surgery alone is really not acceptable. And there is a little bit of a bad reputation with the surgery that we do. And I go to some medical oncology meetings and still hear, people saying that our patients' mortality is about 8 to 10%, which is definitely not the case anymore. I'll show some data about that. One of the landmark trials in the treatment of this disease was the CROSS trial. Finally, it was the first trial that showed a benefit over surgery alone with a combination of chemotherapy and radiation. But when you look at the details of the trial, although the majority of patients were a patient with adenocarcinoma, the benefit really was driven by the squamous population that had a much better response and much better survival with the use combination of chemotherapy and radiation. So over the years, especially in the last 10 years, we've seen kind of a shift in a transition towards a totally chemo-RT protocol for these patients. And then, we started to wonder if radiation is even needed or necessary. And so several trials over the last several years have shown that maybe radiation doesn't really make a big difference. Patients with worse disease, more higher stage, and worse histology actually did similarly or even better when you use chemotherapy alone, because we know that the Achilles heel of this disease is actually micrometastatic spread. It's not just what we do locally, but also what we do in a systemic fashion. And I think as surgeons, we can do a good job locally, and maybe we don't need the help of radiation. And the trial that was recently published and is the EZOPEC trial that really kind of put almost an end, I would say, to the use of radiation, showing that using FLOT, patient had a much better survival and compared to cross, and also a better, kind of similar degree of R0 resection and degree of response. And so with the EZOPEC, what we learn is that FLOT improves disease-free survival because the rate of micrometastatic disease is better controlled when you use stronger and better chemotherapy agent. And however, there is still, especially in our country, a perception that maybe FLOT cannot be used for all patients. That FLOT is very toxic, there are a lot of side effects from the medication, and the patient cannot really tolerate very well. But if you look at the details, even in EZOPEC, and then even more in Matterhorn that we'll hear later, patients actually can tolerate the regimen pretty well and complete it totally. Would use a little bit of ability and expertise to understand and anticipate and treat those side effects before they can really need to be held or change practice or change plan for patients. So these are our first polling questions. Get your phone out and answer the question about treatment planning for resectable gastric cancer. I'll leave a second there. We won't look at answers, but you'll see the answer at the end. So I want to talk a little bit about surgery, how surgery has changed over the years, and that 8 to 10% mortality is really the past. This is a real world data, international, global data. They're collected by an organization called International Society of Disease of the Esophagus that put together all these centers you can see there throughout the entire world. And you can see that the outcomes of surgery is much better than it used to be, with a percentage of pneumonias or other complication that is much lower than what has been previously described, and a very acceptable mortality overall. We also changed what we do technically, and I don't have to say this to surgeons because you all are doing this. We have moved away from doing a big and open procedure to a more minimal invasive approach with robotic and VATS approaches, and we have shown that these are not changing the outcome from an oncological status point of view, but are definitely helping patients to recover faster and to go back, to their daily activity with less risk of complications. And recently, we have witnessed a immunotherapy revolution, the way I like to call it, because immunotherapy kind of came into the practice, and then all of a sudden, it seems like we have seen responses and treatment that we have not seen before. And it's changing a little bit the way we think about treatment of cancer in general. Now, it's a little bit late in the game for esophagogastric, but definitely coming about. Initially, as you know, with the adjuvant CheckMate 577, when we used to do a lot of chemo-RT, that was a good aspect of using immunotherapy as an adjuvant setting for improvement of survival. But now so much more that we're learning from when to use, how to use, patients that have a much more significant response. And my medical oncology colleague will go through some of those data as well. But the access to immunotherapy still is a little bit limited in some community practices. As you know, there are also some discrepancies between what is FDA approved and what is NCCN guidelines recommending. And so although the NCCN line recommend using immunotherapy agents only when we have PD-L1 expression that is high, there are some drugs that are approved from the FDA for use in every patient. And we have some data that we'll look at that seems like most patients, even if they don't have an elevated PD-L1 expression, can benefit from, like in the Matterhorn trial. So there's a little bit of confusion still, probably because it's definitely a new field and a lot that we're learning, and still a little bit of more definition that we need to understand which patients are better treated with immunotherapy today. And since the treatment of these patients is becoming more and more complicated, I think it's key to team up and build these multidisciplinary teams so that you can all be engaged in the treatment of the patients. And so only one provider alone today is not going to be able to do it all. And so we build this big multidisciplinary teams, and we see aspect of patient care that is a little bit different. And we collaborate with each other all the time. And I have to say that I have Sam come to the OR with me, and I really like to say that to people because, often it's hard to know what we do, in our job and how different aspects of the care of patient we are more focused on. And so I think this is very important to build that team in the perioperative setting, but also in the postoperative care of patient. So I'm going to stop at that, and I'm going to introduce for the next talk, Dr. Molena Shah, who's going to talk about the new era of treatment with immunotherapy platforms.
Great. So thank you very much, Dr. Molena. It's great to be here in New Orleans, and thank you. So I think, even before I start, I think, if there's one take-home message about, how things have changed or evolved for esophageal cancer, I think it's that survival has really improved. And the reason why survival has improved because of improvements in surgery, improvements in the way we give chemotherapy, the use of immunotherapy, and multidisciplinary care. Those are the 4 things that really have changed how we manage patients and how survival has improved. So I just want to talk a little bit about immunotherapy in the context of neoadjuvant therapy. And so if you think about immunotherapy, the target cell is actually the activated CD8 T cell. And these CD8 T cells are at a baseline immunosuppressed state, in part because the tumor is expressing immunosuppressive signals, and a patient with cancer already has an immunosuppressive state. If you give immunotherapy in the context of the tumor in place, with chemotherapy, you're able to induce new antigens, you're able to educate T cells in the draining lymph nodes, and these are rationales for why immunotherapy before surgery might have even a better advantage. And that was shown in melanoma as well. Here, this study by Ronan Kelly shows that if you did chemotherapy and radiation, you actually induce immune checkpoints. So by inducing immune checkpoints, you might actually make the tumor more sensitive to immunotherapy because immunotherapy turns off these checkpoints. So this was a very nice study that was done at Hopkins, with chemotherapy and radiation alone. So that was some of the rationale for why immunotherapy in the adjuvant setting might work. And this is what we were just talking about earlier. The idea for adjuvant immunotherapy is that you're removing the tumor, so there's less antigen for the immune system to get educated on. So you can generate a modest immune response. Those are the top panels. The bottom panels are that you're giving immunotherapy while the tumor is in place. You generate a local immune response. You educate the tumor, the infiltrating immune cells by the local regional lymph nodes, and you are potentially able to generate a greater immune response. And that's some of the rationale for giving immunotherapy up front. Checkmate 577 was chemotherapy with radiation followed by surgery in patients who had residual disease at the time of surgery. So about 90% of patients, they went on to receive adjuvant nivolumab. Then you can see a dramatic improvement in disease-free survival, and that actually led to an approval of nivolumab in the adjuvant setting. And I'll just highlight the median survival, 21 months, median DFS, 21 months with nivolumab in the adjuvant setting versus about 11 months with placebo. That's really quite dramatic. And so that, based on that, the FDA did approve it. But we just recently got the updated survival data, and although the hazard ratio is 0.85, p-value 0.1, there's still numerically a significant difference with the role of immunotherapy in this setting. So it does, I think, suggest that there is activity with immunotherapy, perhaps greater for DFS than OS. You know, OS is also colored by the idea that during this era, if patients did have progression, they were able to get immunotherapy in the metastatic setting. So some of these patients may have gotten benefit after progression as well. The Matterhorn study was a practice-changing study. Dr. Molena mentioned it already, but I'll just highlight some additional details. So FLOT is a 3-drug chemotherapy regimen. It is aggressive, and I think as we get used to giving it to more and more patients, I think we'll just adjust. The standard treatment up until Matterhorn was 4 cycles of FLOT. It's a 24-hour infusion every other week for 8 weeks, followed by surgery, followed by 4 additional cycles of FLOT. It's already established that a lot of patients can't get FLOT after surgery. So most people get 4 cycles. Some people do additional 2 cycles and then do surgery because the postoperative administration of FLOT does have toxicity. This study randomized patients to standard perioperative FLOT versus FLOT plus durvalumab, a PD-L1 inhibitor. Here are the demographics. So you can see, as you know, the median age is 62, 63, so generally a healthier, younger population. There was a significant proportion of patients not from Asia, about 80%. 70% were male, so that's typical of the demographics of the disease. This was a gastric and GE junction disease, so about 2/3 of patients were gastric and 1/3 were GE junction. But the GE junction, adenocarcinoma of the GE junction really includes the distal esophagus as well. The Seward type 1 GE junction tumors are really distal esophageal adenocarcinoma. This was an adenocarcinoma only study. We're not talking about squamous cell with regard to Matterhorn. And you can see also the PD-L1 expression. It's done by TAP, which is a tumor area positivity. It's equivalent or concurrent with CPS. 90% were positive. And here is the event-free survival, really quite significant. At 2 years, you're looking at about an 8% improvement in event-free survival. The hazard ratio is about 0.75. And across all different subgroups, you see a benefit really in terms of age, PD-L1 expression, which is an important point that was mentioned earlier, histology as well. And then the overall survival was just updated at ESMO in Germany, and it also is positive, the hazard ratio of 0.78. And so this is a new standard of care, FLOT plus durva for patients that don't have a contraindication to those regimens. And then the important thing is that the application of neoadjuvant durvalumab does improve the pathologic complete response rate. It's now 19% versus 7%. So for adenocarcinoma, we already know that it's less sensitive to radiation. Here, with FLOT and durva, you're getting a nearly 20% path CR rate. So it really has changed the paradigm. But virtually everyone with adenocarcinoma should get chemotherapy with immunotherapy based on these data. And you can see the application of FLOT plus durva didn't really reduce the rates of surgery, or in terms of 90% in both arms. The R0 rate was very similar. So both arms did well from a surgical standpoint. And here I'd like for you to take out your phones and do the second polling question. This is a follow-up polling question on the treatment planning for resectable gastric cancer. And then I think I'm going to invite Dr. Molena up to talk about the surgical experience. Okay. Yeah.
Oh, I can do it. Yeah, so I think it's important for us surgeon to look at this trial critically and really understand, what is about the surgical journey of our patients and how are these new medications going to affect the outcome and the recovery from our surgeries that are already pretty hard and difficult and with a lot of potential for morbidity. So here's a little bit of a busy slide, but you can see that there was really not a significant delay in patients after receiving FLOT durva and completing the neoadjuvant part of the treatment and then going to surgery. Over 86% of patients completed the operation. They were able to go to surgery and have their cancer resected completely. The R0 resection was extremely high, more than 90%. This was for both group, FLOT durva and FLOT placebo. And patient had a pretty good lymphadenectomy. So there were some quality planning for surgical also part of the operation, part of the trial that went into the design of the trial, which I really like about this trial, because often, like the other portion of the trial, the chemo, the radiation, or the other treatment are very, very well, controlled, but then surgery is like, leave it to the surgeon to do whatever they think is right to do. So here there's a little bit of more quality control data, although some data are completely missing. And so we really know how many patients had a full lymphadenectomy, but we don't know exactly how many patients had a thoracic lymphadenectomy, for example, which might more relevant for us. As you know, this was a global trial, so all centers from all over the world were included. And so it's a little bit difficult to standardize completely. Very few patients were not able to arrive to surgery. Most of that was due to progression of disease and not side effects from the procedure. Here you can see some of the side effects, some of the complication. Overall, this is incredibly very good data. Now remind you that a lot of these patients had a distal gastrectomy, for example, or even a total gastrectomy, and maybe doesn't reflect completely, our outcome after esophagectomy. But the 30-day mortality was less than 1.5%, which is really good. And same with the 90-day mortality was extremely very good for a global study with different protocols for doing the operations. Here you can see the benefits in survival based on different groups. The division between gastric cancer and GE junction cancer, although we don't know exactly what kind of operation the GE junction cancer had, especially in relation to thoracic approach. And of course, we know the R0 resection, better lymphadenectomy. These are all data that are not new for us, that we all know that, you can give the best treatment ever to patient, but then if you don't do a good surgery, well, that does not reflect good in terms of outcome. So it's good to have the drugs to treat the systemic portion of the disease, but it's also very good for us to continue doing a really good quality operation and to really offer the full benefit to patients. So there are other trials that are ongoing that we're really waiting for results of because I think it's important, what we are understanding is that not all cancers are the same. And so although we like to discuss, do we do radiation, do we do just chemo, probably the future is more to think about for that specific disease, what kind of approach do you want to use or is best to use? And so there are a lot of ongoing trials that are looking at that, whether patients might have, more a sensitive disease to immunotherapy or other biomarker. I think that is going to be very important to see in the future. And so I'm going to stop here for another polling questions, and then I will let Sam conclude the session. Then we'll have a little bit of a discussion for a couple of cases. And so please participate, ask questions, and get involved.
Yeah, thank you for the introduction and being able to join a surgical conference here. So before we get into the cases, this will kind of prime us and talk about some of the practical components of FLOT, thinking about it from a safety perspective and hopefully demystifying some of the worries that come with giving FLOT. One, rough and perhaps fast and dirty rule that I have is if a patient is an appropriate candidate for an esophagectomy, for a major surgery, then that tends to be a good rule of thumb that they are likely to be able to tolerate some amount of FLOT, maybe not incomplete, but some components of it. It is a rare patient who would be able to be a good esophagectomy candidate, but not a candidate for FLOT. And the second point I want to highlight is, as has been mentioned, this was a global study. And this was enrolling patients prior to the SOPEC readout, which means that not only was this being administered around the world, but it was being administered when concurrent chemotherapy and radiation was more prevalent. And so local oncologists, community oncologists' experience with giving FLOT is certainly a lot less than even anecdotally we've seen from our second opinions over the last year and 18 months since the Matterhorn readout and the SOPEC readout shortly before that. And as we see, the addition of durvalumab to perioperative FLOT did not increase the rate of adverse events. A majority of patients do experience grade 3 or higher adverse events, so certainly it is an intense regimen, but certainly manageable. And as we see, durvalumab, a PD-L1 inhibitor, the adverse events that were immune-mediated, very consistent with what we see with this category of therapies. And taking a step back and looking at them side by side, the majority of these adverse events are really GI tox and cytopenias. And we've become a lot better at proactively managing these as we become more experienced with giving FLOT. We see diarrhea and nausea at the top, but really neutropenia leading to a lot of treatment delays. In the study, there was no mandated whether or not they had to give growth factor, but we can talk about some of the tips and tricks to take back to the medical oncologists. And so looking first at chemotherapy, which does drive the majority of the toxicity, especially in the neoadjuvant preoperative setting, we see that about a quarter of patients had to discontinue treatment. We're not able to get adjuvant treatment, as we talked about. It's much more difficult. And you can see here a lot of patients, a small number of patients do end up having to discontinue some component of the chemotherapy, and not shown here is there are also dose reductions that go on, but that's a part of becoming more accustomed to FLOT. And then here we see one of the most common reasons for discontinuing therapy is the peripheral neuropathy, which is caused by both docetaxel and oxaliplatin. So those tend to be some of the first chemotherapies that we either dose reduce or de-escalate, particularly in the adjuvant setting when toxicity is greater. But as we move to thinking about delivery, obviously those who receive more FLOT, this is confounded by those who are more fit than those who are unable to. But nevertheless, the addition of durvalumab, and we'll talk a little bit about why it occurred a benefit in those even who didn't get as much FLOT. And when we think about the toxicity of immunotherapy specifically, this can be systemic, right? And the way I explained it to patients is your immune system becoming overzealous. Dr. Shah took us nicely through some of the more translational science. And I'll brush relatively quickly through some of this because we all know it well, but it can really span a spectrum, not just in organ system that's involved, but also in severity, whether it's mild and can be managed with topical agents that don't require any treatment interruption or requires a brief pause of immunotherapy, or whether it requires more permanent discontinuation and administration of systemic immunosuppression, whether they be steroids or TNF-alpha inhibitors like infliximab. But these are also toxicities that we're becoming more comfortable managing ourselves as medical oncologists, but also working very closely with our multidisciplinary teams, particularly gastroenterologists who are seeing this more and more. this is a very common figure, at least in some of the medical oncology talks, but life doesn't fit so cleanly into each of these time points. And really what we do see, though, more broadly, is that it is rare to have an immune-related toxicity, certainly within the first month. And for the majority of them, they occur 2 to 6 months out, meaning those first 2 months of neoadjuvant therapy, the addition of durvalumab, as was shown on the surgical slides before, does not inhibit curative surgery. And that's really important, because obviously you want a drug that's active and efficacious, but that is not impeding curative surgery. And so the adjuvant setting tends to be where we see more of these immune-related adverse events. And as Dr. Shah showed on some of the earlier preclinical data, we really do believe it is the neoadjuvant checkpoint inhibition that's driving the majority of the benefit here. But you see that even though the majority of immune-related adverse events occur in that 2 to 6 month window, they certainly can occur sooner or even much further out. And so this is, will prime us to talk about some of the cases, but what's outlined here is very much what I do in my practice, and it's all about being proactive. So for cytopenias, it doesn't matter how old or how young you are, because we've been surprised by young patients with relatively poor bone marrow reserve. When they come back for their disconnect of the 5-FU, they're getting Neulasta to make sure that their counts are safe and appropriate for cycle 2, staying ahead of the game. And then number 2 is intense antiemetic prophylaxis with IV aprepitant on day of treatment, olanzapine starting at night, the day of treatment, and at least for a few days after, and then dexamethasone on days 2 and 3. And this really keeps, and then you can de-escalate from there, but this really keeps you out in front. And then I also give IV hydration when they're coming back for disconnect and Neulasta. And I think overall, as our medical oncology colleagues become more and more familiar with giving FLOT, maybe not even starting full dose, but understanding that triplet is better than doublet, that the addition of immune checkpoint blockade to chemo is overall certainly superior to chemoradiation, that this will be more and more widely adopted. And so I will leave it there and make sure we have some time to go through cases and questions.
All right, so we'll start with some cases. I'm going to put you guys both on the spot. But if you have questions regarding the cases, just raise your hand or send it to the app. So we have a 66-year-old woman who has been complaining of dysphagia for the last 3 months and also weight loss. She goes through the, endoscopy and then staging process and was diagnosed with a clinical T2 N1 M0 poorly differentiated GE junction cancer. Her previous medical history are hypertension and hyperlipidemia and Hashimoto's disorder. And she also had a hernia repair, which for our surgeons is important to know, right? Because it might affect what we do at the type of surgery. So here I'm going to show some pictures of her PET. You can see, I'm going to use a mouse for that, right? Her hernia repair, maybe not so well still working after the years. She has a recurrence of a hernia, and she has a little bit of uptake that you can see also here, right? The GE junction, maybe, it's hard with just the PET alone, but we don't know exactly what the GE junction here is with a recurrent hernia, but maybe cardia a little bit as well. So any other information that we want to know? Here, so the histology is a poorly differentiated adeno, unfortunately has signet ring cells, and we have some biomarkers that were done, unfortunately nothing really good to look at, right? So what are we gonna do? I think we have questions here. So what are we gonna do with this woman? What do you think about her treatment? What are the considerations that you have? Is the histology gonna make a difference? What's your process of thinking when you see a patient like this? from a medical oncologist. Then I tell you from a surgical perspective what I think too.
Well, I think one of the first things that you mentioned about the extension into the cardia is, does this patient need a diagnostic laparoscopy? And so we obviously always talk does that warrant a diagnostic laparoscopy? Because we know that about 10 to 15% of patients, particularly with diffuse type tumors, can have occult peritoneal disease that isn't evident on imaging. But let's presume that that's not the case. What I would be thinking about here is, this is a locally advanced tumor, and although it is PD-L1 negative, which was about 10% of the patients on the Matterhorn trial, so certainly not powered for that subgroup, there does still seem to be benefit, and this is one of the discrepancies you were talking about earlier, that NCCN has listed it as category 1 for PD-L1 TAP greater than 1, and 2B for less than 1, although it is FDA approved irrespective. And so, in my practice, irrespective of PD-L1 status, this is a patient who would get perioperative FLOT with durvalumab.
Are you guys at all worried about Hashimoto's disorder? Are you considering that, or is that a completely exclusion criteria, or?
Yeah, so that's a great question. So in the development of immunotherapy, there were, I guess, some relative contraindications, and one of them is patients with autoimmune disorders already. So Crohn's disease, ulcerative colitis, Hashimoto's thyroiditis, but even rheumatoid arthritis or Sjogren's syndrome, things like that. Since then, the NCI has done a study, which is still ongoing, of giving immunotherapy in patients that have these conditions. And remarkably, between 50% to 2/3 of patients are able to get immunotherapy and still manage their autoimmunity. So I think it's a relative contraindication, not an absolute. So, I think if you're giving a checkpoint inhibitor, certainly Hashimoto's thyroiditis wouldn't be an absolute contraindication. And the other thing I would say is that the autoimmune side effects are worse with dual checkpoint inhibition. So when you're combining a PD-1 with a CTLA-4 inhibitor, here durvalumab is PD-L1, it's by itself. So, and then the last thing, as Dr. Cytryn mentioned, is that most of the toxicities from immunotherapies don't happen in the first month or two. And then you're pausing and getting surgery. So you might, I think all of those things mitigate the risk in terms of that type of thing. And I think, so I guess the first question is, the patient's young, in her 60s, no other really medical problems, so presumably the patient is a surgical candidate. But I think that would be, a question from a multidisciplinary standpoint, how much does a hiatal hernia affect everything, and whether or not that would make surgery a little bit more complicated. Yeah. So I guess I would throw that question back to you.
It's a consideration, right? And I wanted to put everybody in the room a little bit on the spot, right? So you have a patient like that, and so raise your hand. Who would do gastrectomy on this patient? How about an esophagectomy? That's nice thoracic surgeons in the room. That's great. But, what Sam said at the beginning, this is a patient that absolutely I would want to do a staging laparoscopy. Not only because I want to see the peritoneum, but sometimes the staging laparoscopy for me is to look at the stomach. I want to see the stomach from the inside, and I want to see the stomach from the outside, because often the report or the description from the gastroenterologist is not really adequate. And they are not doing the endoscopy with the same mentality that we have. Like, I'm thinking about reconstruction and resection. They're just trying to diagnose a disease. So staging laparoscopy, in my opinion, is very important in this situation to look how much stomach do I have, how down really does this tumor go, right? And do I have a margin distally? And also give you a little bit of an idea how much adhesion you have, scar tissue. In my experience, actually, after a hernia repair, your stomach is really well conditioned. They're already taking down the short gastric, all the tip of the stomach that usually is at risk of ischemia. If you're doing a good job in dissecting it without injuring the stomach, you have a much better perfused conduit that you would have if you did not have the hernia. But with signet ring cell histology, that's even a very important point for diffuse disease into the stomach. And actually, we have to look at MSK, at our own data. For esophagus cancer, esophagus and GE junction cancer, with signet ring histology, and we show that these patients can also have peritoneal disease. So when you see that type of histology, just you want to work them up. You want to make sure you're comfortable, because there's nothing worse than being in the operating room with a positive margin on the stomach, right? And you're already your esophagus. What do you do in that situation? It's not comfortable. So, so she did, in fact, had her flawed durva, and she had a good response. She went on and had surgery. She had a minimally invasive esophagectomy, no complications. And you can see here that her pathology at the end was not that great. Like, I see that sometime, right? You see that patients do well, they eat better, their looks a lot better, and then you look at the pathology, you're like, oh my God, it's not really a great response. So what do we do with this patient now?
The definition of insanity is to do the same thing again and expect a different result, right? But that's kind of what we're left with, unfortunately, and that's one of the many things that motivates me separately to try and come up with better treatments. But in someone who has, regardless of what their biomarkers are, as far as what's approved, the best thing for this patient to try and improve their disease-free time is to, if they are fit and have recovered well enough and would be able to tolerate it, begin with adjuvant chemotherapy and durvalumab. And there are a number of studies that have looked at, prior to the Matterhorn era, substituting out FLOT for dual checkpoint inhibition without chemotherapy, and that investigational arm actually had a shorter recurrence and was closed because of detriment, the Vestige trial. And then the stopgap was a observational study that was looking at patients who received FLOT based on their response, and in patients who had some response, they still had some benefit, even if they still had a lot of residual disease. So it is not a comfortable conversation, and I don't feel good about it, because the likelihood that this patient is going to have recurrence is unfortunately quite high, yet triplet chemotherapy with a checkpoint inhibitor is the best thing we have.
Manish, what do you think?
Yeah, so I do agree that the patient should continue treatment as long as she tolerated it well beforehand with the FLOT and durva. We heard very strongly from Dr. Cytryn that he would give durva independent of the PD-L1 status, and I think that that's very defensible. I think that there are other studies that show less benefit or maybe no benefit with the PD-L1 less than 1. So when you look at the data all together, I think that durva may or may not have benefit, but the harm is probably pretty low. In this situation, at the time of surgery, the CPS didn't bump. And we see that often, that the baseline CPS might be less than 1, but then after treatment, the CPS can bump. And for me, I guess in this situation, I don't feel so strongly that I would continue durva, because then now you're getting into the higher chance of toxicity, because you have adrenal issues and thyroid. I mean, she already has thyroid stuff. That all being said, I think where we need to move is actually how do we change the field? Because I think Dr. Cytryn, basically is calling us all insane, but we would think about how can we move the field. So one thing that people are looking at is the application of ctDNA. So these patients might have a higher risk of being ctDNA positive or being positive earlier. And right now, we don't have data to support acting on that ctDNA. So we're developing that, as a clinical trial to sort of see can we act on that, as an indicator of micrometastatic disease, where we change therapy to maybe have a different outcome. The intent of treatment in the preoperative and adjuvant setting is to improve the chance of cure. And I think we're unlikely to do that in this case because of the advanced stage even after treatment. So I think we do need to think of new treatment options. But unfortunately, the best data we have now is to continue FLOT-based treatment, because it is better than doing nothing.
Yeah. So Very, very good discussion, but I always struggle. I know when patients come back with this, and I'm like, I wish I had something better to give. Although the Matterhorn does show that even with positive nodal disease, patient did better when they completed the treatment. So see if we have a little bit of time maybe to have one more case. This is a little bit more controversial, but we see a lot of these patients now very young. This is a 45-year-old patient of mine, dysphagia weight loss. Usually they take a little longer to get worked out because who believes a young person like this have cancer? And so by the time he got diagnosed and staged, he has, as you can see in the picture here, peritoneal disease. So otherwise healthy, diabetes and GERD, no other surgical history. And so now that we have these new drugs, a new option for treatment, do we push the envelope in these patients? You know, that this is a clear metastatic disease, right? Retroperitoneal nodes. I know Renaissance trial showed maybe some benefit in this specific situation, but I'd love to, so I show you the histology here. So this patient, he's MMR proficient, but he does have a CPS of 40. So wonder if you would think about doing something a little bit out of the box here.
Yeah, I think, you know, so this is not a patient for whom I would give FLOT and durvalumab, right? This is not a short neoadjuvant systemic therapy course, as you mentioned. Obviously, this is, you know, unfortunately stage 4. But for patients with distant lymph node and no visceral disease, there are some patients who, after a prolonged course of systemic therapy, and we learn over the time of their treatment that perhaps they have more sensitive disease biology. You know, PD-L1 CPS is the best predictor we have of that outside of mismatch repair deficiency. But then perhaps, you know, on the order of 6 to 12 month window, and discussing it, of course, with our surgical colleagues, that, you know, resection and perhaps a retroperitoneal lymphadenectomy can be appropriate in some situations.
Manish, what do you think?
Yeah.
Palliative only, or do we give him a shot? 45-year-old.
No, right. So in other GI diseases, particularly colon cancer, patients with limited metastatic disease, so this would be limited, there is a survival benefit with chasing it, meaning doing systemic therapy, taking out the primary, and then eradicating the metastatic disease. And I think that's what the Renaissance trial suggested, that that's what they were testing in that study. And so that was a study of 4 cycles of FLOT, and then patients were randomized to receive additional FLOT or to address the primary and address the metastatic lesions, and then any systemic therapy afterwards. And it was a negative study. 1, it was probably underpowered, and 2, the way it was designed, it takes away the judgment of which patients should get aggressive local regional treatment and metastatectomy. I think we've all had patients with limited metastatic disease that have long-term survival. I've had it with patients with isolated lung lesion, retroperitoneal lymph nodes, an isolated liver lesion. You don't know who's going to have benefit, so you give patients a benefit out. So I would definitely do systemic therapy with immunotherapy. The CPS 40 is a great prognostic indicator, and I would definitely, if the patient had a major response and did not have any progression after, and this is where we need more data, but in my practice, 4 to 8 months, I go after it. I talk to the surgeon about doing an esophagectomy and then either radiating the lymph node or sometimes, depending on what the surgeon wants, to resect it. And there are patients that have long-term survival in that setting. That being said, I think that here we also need to figure out how to apply better technology. Maybe it's ctDNA, maybe it's something else. Maybe it's something more about the biology to figure out which patients we should chase to try to change the outcome.
Yeah, I think that's absolutely, and I agree with all of that. It's hard to know, right? We don't have enough data. I disagree with the Renaissance design, and I think that just doing neoadjuvant in this patient is probably not enough. We don't want to do this big operation and then have patient recur right away. We just really want to give benefit of the doubt. I think that definitely a staging laparoscopy I haven't mentioned, but with that gastric extension, I want to know if there is any stomach. I didn't show you up, but that definitely goes up in the esophagus that you're not going to be able to do just a regular gastrectomy in a patient like this. We already went through the questions. So actually, we do have now a protocol, so we can study a little bit these patients better. And we decided to, we do at least about 6 months of chemo IO before we consider doing surgery on these patients. And then, like what kind of surgery do you do? And I think this is kind of open field. To be honest, I don't know. He had a great response. I wish I can show you the PET after treatment. And so it's really hard to know if there is still tumor in the lymph nodes or not. We opted to go and resect everything that was disease at diagnosis. So we did an esophagectomy and also a retroperitoneal dissection. I have a colleague from urology that helps me with that because it's not a place that I'm familiar with. I don't go up there and taking lymph nodes out in the retroperitoneum, but they do it all the time for their urological disease. And patient had all nodes, they're negative. So, great response this time, much better response. All nodes are negative. T2 and 0 at the end are 0 resection. What do we do with him now? He has already gotten 6 months of chemo IO. We're all happy and celebrating, but we know he's still a high-risk patient, right? He had metastatic disease. So do we just give ourselves a pat on the back and say, oh, good, or do we do more? Is that necessary to do more on this situation?
It's certainly an open question and an evidence-free zone. I would say there's no need to do more, but one of the takeaways that from both Checkmate 577 and the Matterhorn study, and there's it's somewhat arbitrary, this idea of a year of checkpoint inhibition, but I tend to extrapolate that and wouldn't give adjuvant chemotherapy at this point, but if they've tolerated it well, they've seemed to have a good response, though certainly some residual disease, it's a discussion about consideration for an additional 6 months of immunotherapy, and then, close surveillance or just close surveillance at this point.
Yeah, so I think it's, it is a data-free zone, or so I like to say, unburdened by data, I can do kind of what I think makes sense. But so I depending on how the patient tolerated the chemo, I mean, we don't know that more chemo is better. That being said, there are data in the metastatic setting. So in the UK, they do 6 months of chemo and then they stop treatment. And but that's not the convention in the rest of the world. In the rest of the world, it's sort of chemo until progression. This is in the first-line treatment setting. This is stage 4 NED, and so in that setting, I'm a little bit uncomfortable stopping chemo entirely, although I take Dr. Cytryn's point very well. But I might do 5-FU and immunotherapy kind of post-operatively. It's hard to know how long even. I mean, stop at 6 months, stop at 18 months, I don't know. I've done the whole gamut, but because I've been around for a while, and I don't know that there's one right answer.
So a lot more complicated disease is going to come your way. But I wanted to not cut any time to our Q&A. So we have another polling questions for your prize here. Understanding new and emerging evidence for perioperative systemic therapy. And I have a lot of questions already that came up. So we will go and jump right into, first I'm going to do a summary. So as you have heard, chemoimmunotherapy is a cornerstone for treatment of this adenocarcinoma, the G junction and gastric, and we do it for esophagus now too. And it is very important to understand, evaluate the patient and make sure that there is a multimodality and multidisciplinary approach to evaluating them, and also maybe to rehabilitate them so they are stronger for treatment. It is, perioperative durvalumab and FLOT now is kind of standard of care for this disease and is included in the recent NCCN guidelines. And we hope that maybe, more options in the future will come about and we improve the outcome of the disease even more and better. Okay, so we'll jump right in our Q&A because we don't want to miss that. And so please, if you have a question, raise your hand. We have microphones in the room. Somebody will come and get your microphone, but I have some questions that came in. So, and I'm going to split this question in two, right? The first question is, what do you do with PCR? So if you have a patient that had a complete response after this treatment, what do you do in the adjuvant setting? Quick question so we can go through all the questions that we have. Quick answer, Aman.
If they tolerated neoadjuvant very well, I very cautiously trial them on adjuvant chemoimmunotherapy with a very low threshold to de-escalate.
Yeah, I agree. I think we don't have data to stop therapy, so we would continue based on tolerance.
About monotherapy durva alone in the adjuvant setting, would that be enough in either a patient that responded or patient that did not respond completely?
So I think this is also a data-free zone. So I think we're hesitant to stop the chemo unless the patient didn't tolerate it. And it was said earlier that a lot of patients don't tolerate postoperative therapy because of comorbidity or sort of recovery from the surgery. So I would say in my practice, maybe half the patients don't get postoperative therapy, but they're able to get durvalumab, and about the other half start a reduced dose of FLOT and then maybe get 1 or 2 cycles and then we stop. So it's again not based on data of efficacy, but more based on just tolerance.
That's great. So I'm going to ask you a tough question. When we had a chemo RT and we had a what we call clinical complete response, which is really not, something that is well defined, right? But we had that option, patient didn't do so well with treatment or had a great response. We had that option of watching patient. What do you do now with this new paradigm of chemoimmunotherapy? Do you decide up front which patient would and would not tolerate surgery and then give them chemo RT if you think they're not really great surgical candidate? Or is the clinical complete response after durva FLOT equivalent to the clinical complete response in the cross era? That's a tough question, but I wonder about that a lot.
I might even argue that, from a practical perspective, someone with a clinical complete response who was a surgical candidate to start and remains a surgical candidate, I encourage, they should get surgery, yeah. Right, full stop. Outside, barring any clinical trial that's looking at otherwise. But a clinical complete response from systemic therapy alone is in fact more impressive and portends a better prognosis than a clinical complete response that was augmented by radiation.
Yeah, I think that's probably fair, and I think that the data show that out. So a chance of a clinical complete response with chemoradiation is close to 40%, depending on how long you wait and when you look, compared to about 20%. Well, that was pathologic. Maybe a clinical complete response with chemoimmunotherapy might be 20 to 30% or something. That being said, I think that if patients are non-surgical candidates, and there are guidelines on this, I think that the question that you're asking is, should they get chemoimmunotherapy or should they get definitive chemoradiation? Whether it's with immunotherapy or not, that data is coming out and then monitored. And I don't think that we have the answer to that question specifically, but I think that in our practice, we do the best we can to sort of say most likely not to get to surgery, and then in which case I think radiation should be a component of the treatment, whether you do it up front as a definitive chemoradiation approach or after a course of chemoimmunotherapy, because maybe the performance status changes. These are the nuances.
Because the PCR in Matterhorn was 19%. It's not far off the PCR on Cross for adenocarcinoma, right? And we all agree that, with that, we watch patient with a clinical complete response. So I feel like we need better tool to really identify these patients that might have had, because I agree. I think that PCR with chemoimmunotherapy might be better overall prognosis than PCR after chemo RT, but we need better tool to identify those patients. Maybe surgery is not really definitely needed, or helpful.
Yeah, and chemo RT is no picnic. So starting with, perhaps doublet chemotherapy and immunotherapy to not just learn a little bit, maybe improve their clinical, performance status as you have tumor regression and they're able to eat, but you learn more about their performance status and tolerability, but also more about the disease biology, but before then perhaps consolidating with definitive chemo RT if they remain not a surgical candidate.
So in that same line, I'm going to ask one last question because the time is almost running out. But is there any patient that you would go directly to surgery? They would advise, let's not do even neoadjuvant. I know it's really different here than in Asia. A lot of Asian patients go directly to surgery. But what's your thoughts about going to surgery first? And which patient would you recommend that?
Yeah, so, patients that have mismatch repair deficient tumors, it's, I think, pretty well established that chemotherapy or chemoradiation could be even detrimental. So there, based on some small phase 2 studies, you could consider immunotherapy and not doing surgery. But if it's relatively on the early side, I'm not even sure that's the right thing to do. I think that patient, you might benefit from surgery alone and then seeing what happens. But, I think that is, and I guess the other population are those that are, failed ESD, you have, positive margin or deeper tumor. There, you would think maybe not doing any treatment and just going to surgery.
Mm-hmm. I think sometimes even really kind of elderly patient, them a little borderline, sometimes it's really hard to give it all to a patient. You have to pick which one is the one treatment that might make a difference. I think, I don't know if my colleagues from medical oncology agree with that, but as far as now, I think still surgery does the heavy lifting of cure for now. I know you guys think that maybe surgery will not be needed in the future, but...
No, for sure. Surgery is the key component of it. The question is what will they be like afterwards?
Yeah. Well, people that can eat and are not really having really bad dysphagia might recover a little bit better to a point where they can tolerate something adjuvantly. And I feel like sometimes it's really hard to give neoadjuvant to somebody who's really frail, cannot eat, it's going to decompensate even more, and then you're really not going to be able to do any surgery at all at that point. I think that maybe we'll stop here. There are a lot of other questions and discussion, but I think this was really fun. So thank you, everybody, for joining us today and learning about this disease. I think more and more is coming on the market here for us to use. And I think that our collaboration between surgeons and medical oncology is key for us to get patients to improve their outcome and have a much better survival. And don't forget to look at your phone to see if you won the prize, which I don't even know what the prize is. What is that? Oh, that's right, $50 gift card. Yeah, that's right, it was in the beginning. So good luck.
Thank you very much.
Thank you.